This is Duncan Turner from the Vagina Doctor podcast. Welcome to the Consult With Me segment where we take a deeper look into our most frequently asked questions. But what do I know? I'm just a vagina doctor.
Okay, so today's question actually is a question that I have because, we talk to patients all the time and you actually consult with patients all the time, but now I need to be the patient because some things have changed with me turning 59 this year suddenly. And yes, of course, I've been doing things in the office, not as much as people would think, like, oh, you could get stuff all the time, but really I'm usually too busy to be getting things.
You always put the patient first. And we might schedule you for a procedure and then another patient shows up and wants an appointment and you give up your appointment.
Right.
So it's not all my fault.
No, it's totally my fault. But so here I am and I'm having these new symptoms of almost like burning pain. And it's all the time I feel it. And then some vaginal dryness, but I've done the Mona Lisa, so that really takes care of that. But I've been getting more pain with intercourse just on one side. But I have to say the biggest change in symptoms is the burning, and I feel it throughout the day.
Well, first of all, I want to, you make reference to Mona Lisa, which is the laser treatment that we've used for vaginal dryness and pain with intercourse, which works really, really well. And that's been our workhorse for 7 years now and changed the practice when it came along. The truth there is that, yes, it's effective. It usually takes 3 treatments to be productive, but it needs to be repeated. And it should be repeated perhaps once every year or so because the physiological changes are not resolving. And they won't resolve because of the lack of estrogen.
So what's changing right now? What's the burning?
Well, you're on full body systemic hormone replacement therapy, which raises your blood levels of estrogen particularly, and has lots of benefits. But the vaginal tissues require more than that whole body treatment. They're very, very sensitive, and so more estrogen is necessary just in the pelvis and usually applied vaginally as a cream or a suppository, and is extremely effective. But it needs to be done. And all of the symptoms are because of lack of estrogen. You might use other things to help them with lubricants and hyaluronic acid and that type of thing, but estrogen's a missing ingredient. And those other things are only if we can't use estrogen or in conjunction with using estrogen. But estrogen is the missing ingredient.
Okay, so I have kind of played around a little bit with the vaginal suppositories, and I didn't really like them because of like the discharge and things like that.
Right.
And since I've been talking about this with you, all these things, and it might be from the Vagina Doctor podcast too, but the amount of ads and stuff, sponsored stuff popping up on my phone for hyaluronic vaginal inserts, and then there's the estrogen vaginal. What's the difference? Because hyaluronic, that's a real buzzword. So if you add that to the vagina, is that enough, or do I need more?
It's not usually enough, and it's really missing the point. We have availability of the compound, or actually the bioidentical hormone that's missing, and it's really just a matter of finding some delivery system that works best for you. Often the first prescribed by physicians is a vaginal cream, and that's really messy, and people don't like it for that reason. There are little pills that are just bioidentical estrogen, which are probably the best way, and they've been around for a long time. It's a very, very low dose. There is really no risk involved with it whatsoever. It's about 1% of a normal full body dose. It doesn't change blood levels at all. It's perfectly okay to be used in patients that have had endometrial cancer or breast cancer. And that's usually used once at night for a few weeks and then a few times a week thereafter with really good effect. And I think that that's a cure for this, or at least the solution which needs to be continued to be used. But it's a little bit of a nuisance to have to do that for patients, and they kind of fall off the wagon.
Well, also, I mean, so many calls, Duncan, every week about women, and we send these prescriptions through, or you do, and it's not covered by their
Right.
insurance, which to me is unbelievable. I really, it's not right. It's one of the many things not right in women's health.
I agree completely. And the insurance companies are really about conserving costs for themselves. And the creams, particularly a non-bioidentical cream called Premarin, works really well, but it's not the best for it. That is often the first choice, or the one that's allowed by the insurance companies. If patients don't want to do that, they're sort of stuck. And that the only way the insurance companies will generally change is if there is some intolerance to some ingredient in that method. And so we have to get pre-authorization, or patients pay out of pocket. And paying out of pocket is ridiculous because it's $300 a month, whereas with
it's
insurance,
not sustainable. Yeah,
absolutely.
And so then we turn to Harbor Compounding, which they're actually coming on the podcast next month. But having them compound,
we can get them to
medication.
compound medication as we want it. And they're allowed to compound as long as it's not something that is actually available by prescription from a regular pharmacy.
But even when it's
company.
too expensive, they still can't do that?
No, so we make it slightly different. We have them compound it differently that isn't available, and it works really well. And this works out to be about $75 a month.
Okay, so I
less.
need to get that. So we need to call Harbor Compounding
We'll do that today.
Okay, do that today. Okay. Well, more to come on that and Harbor Compounding. But so besides getting this suppository, which I definitely want to do today, and repeating the Mona Lisa, I even think I might need 3 more Mona Lisas.
You might. It's been a while.
Yeah.
So that's not unusual. And it does not appear that there is any long-term concern about doing multiple vaginal rejuvenation procedures. And that's the first of them. There are others. That, as I said, that was the first one available. Now we have maybe slightly more aggressive treatments.
Yeah, but I don't like those. They're too aggressive. I'm too sensitive.
You're too sensitive.
No, I know they're enormously popular in the office, but I'm sticking with the Mona Lisa.
Good.
Okay. Well, thanks for letting me be your patient today.
My pleasure. No pun intended.
Thanks for listening. And if you have more questions, please let us know either by email or DM us on the Vagina Doctor podcast.
See you in the next episode. The Vagina Doctor podcast. It all starts here.